Tēnā koutou katoa. Welcome everyone to our fourth webinar, which is on regulation and legislation. It's a great pleasure for the New Zealand Telehealth Leadership Group to be presenting this webinar. You'll find more about us at www.telehealth.org.nz, but basically we're advisory and supported by the Ministry of Health to get out there and advocate for telehealth and support all you wonderful users to do the right thing for your patients. Today we're going to be talking about regulation and legislation, and in a minute I'll get our panel to introduce themselves, but I think what we're looking at now is we're moving out of our lockdown periods and into our COVID level 1, if you like, and I think what's interesting now is to see the changes that we've made, what's going to be sustained and how we move on, particularly around legislation and gosh, that's really hard to say, isn't it? Legislation and regulation. So the only real things we want people to stick on is the term of telehealth, which of course is the delivery of healthcare where the patient and the provider are in a different location. So that's our definition of telehealth. And also that our definition of in-person, which is when you are actually physically in person with someone. So we're shying away from that term face-to-face, which can mean just like we are having this conversation together now. So I'm going to start with some introductions, and I'm going to go with my top left, which is Dr. Curtis Walker. Thank you.
Tēnei te mihi atu ki a koutou, kua tai mai nei, marunga I o koutou roro hiko, tēnei te mihi atu, tēnei te mihi ki ngā kaimahi, ki ngā kaiwhakahari o tātou nei hui, tēnā koutou, tēnā tātou, koe hui hui mai nei. It's a pleasure to be here as chair of the New Zealand Medical Council. I also happen to be on the board of the Māori Doctors Association and a proud jobbing renal physician in Palmerston North, and that's from phoning in from tonight. So look, thank you for the organisers for the opportunity to be here to hopefully be of use to the people listening in as the chair of Medical Council and talking about our statements, standards, the regulation in this area, but most keen actually also though to listen to what the conversation might bring up in terms of how we can be facilitative of what the future looks like, while also maintaining that essential professional safety of practice. So kia ora, and thank you again for the chance.
Kia ora, Curtis, thank you very much. Diana.
Kia ora koutou. My name is Diana Aquilina. I'm Senior Legal Counsel at Waikato DHB. And so I've been advised a lot in advising on rolling out telehealth in the DHB. So yeah, really looking forward to today's discussion, and yeah, thanks for having me along.
Awesome, thank you, Diana. Kia ora, Rommel.
Kia ora koutou. Thank you, Ruth, for this invitation to be part of this panel, and thank you to the other 20 people that said no. Make space for me. Look, I'm Rommel Anthony. I work for the data and digital team within the Ministry of Health, and my main mission is to support the Medication Management Digital Services Program, which is the custodian of a number of really important sector taonga, like the New Zealand Formulary, which and the Universal List of Medicines and the New Zealand e-prescription service. So like the rest of you, it's been a really busy couple of months, and we've really not let this pandemic go to waste. We've been part of the really hard mahi around helping services use remote prescribing as part of telehealth-based models of care that has seen us get through, level 4 to where we are today. But so it's a real privilege to be part of this discussion, because as part of the medications work, I get to hear from a wide range of clinicians and vendors about new and exciting solutions and models of care, but frequently come up with, regulatory brick walls, whether real or perceived. So it's really, really useful to be part of this discussion and to hear about what's not working as in the medication space. We kind of start focusing towards redesigning that regulatory framework for a future that supports new models of care, both ones we use now and ones we can't even imagine today. So thank you for inviting me.
Excellent. Thank you so much, Rommel. Kia ora, Jane.
Kia ora. I'm Jane King and I'm the Associate Commissioner Legal at Health and Disability Commissioner. So I'm their Chief Legal Officer, and really our focus is on rights of consumers and rights of consumers in all situations as the models of care change. So I'm delighted to be here and thanks for the invitation.
Excellent. Thanks so much, Jane. Kia ora, Sam. Oh, I better say Sam King because we've got two Sams. Hey, Sam King.
Hi, my name's Dr. Sam King and I'm a medical advisor with Medical Protection. We provide medical indemnity or professional indemnity for mostly doctors, but we also have nurses and physios and clinical psychologists, etc., that we assist. My background is general practice and I work out of Auckland. It's been an interesting space actually getting into telehealth, and it wasn't so much that I have an interest in telehealth, except that with the onset of COVID-19, and of course everybody had to move there very quickly, particularly general practice, it became very clear that a lot of our members have a lot of anxiety around the space and how to do it safely. And so it has quickly become an interest of mine to be able to reassure our members, but also to give them advice as to how you can practice telehealth safely, and it can be done safely. And I think actually it's the way of the future. So I think it is here to stay. So I think this is great what you're doing, Ruth and the team, and thank you for having me back.
Excellent, thank you so much. And our other Dr. Sam, Kia ora, Sam Merton.
Kia ora. Yeah, so I'm Sam Merton. I'm the president of the Royal New Zealand College of GPs. And it's great to be back at this session again and listening to everyone talk, and especially good job Rommel and his team for the NZEPS stuff that's gone up, and it's been fantastic. And I think from the sector point of view and our members' point of view, they've been a few glitches and struggles, but it's been really amazing to be able to have that electronic prescribing so easily transformed into the service that we now use. So it's been great. I think we all do still worry about whether we are doing the right thing by our patients, and I think it's important for us to have these discussions regularly. But I also believe that it is the way of the future, and for access to many health services, telehealth is almost essential, and so it's good for us to make sure that we are doing it well and providing the services that we can for our patients, the ones that we know and know well, because it's much better that they are with a clinician who knows them than getting acute care from somewhere else who may not know them so well and know what they need. So great job. It's good to have you all on board. Yeah.
Great, thanks very much, Sam. Now keep those questions coming. There's a few already I can see there, but I'd just like to kick off the conversation picking up on the points that the panelists have already raised, which is really about safety. You know, what defines safety? How do we keep ourselves and our patients safe when we supply care via mechanisms like telehealth, which obviously includes video, phone, text and email. Curtis, do you want to kick that conversation off?
Thank you. Sorry, the Q&A thing was in the way and I spacebarred and something else happened. I think it's still safe. I think that's the key right there. Yeah, from the Medical Council's point of view, it's really about, and you know, no doubt everybody who's listening to this webinar, the key is maintaining patient safety. You can do that in a variety of ways, but at the end of the day, it still comes down to having an understanding of the problem that you're dealing with, the problem that the patient is coming to you with, the nature of the healthcare that you're delivering, and can you have sufficient information through the mechanism that you're employing to do the consultation. And at certain times that is going to be sufficient over a telephone without video. At certain other times it's going to be actually, look, we need a video there, and I'm going to get some cues here. I want to see the rash, or can I get an email of the photograph of whatever it is we might be dealing with. Up to, of course, actually we need another person in the room with you to do certain things, whether it's as simple as a blood pressure or as complicated as an more thorough traditional physical examination. to supplement what you're doing, along with all the electronic tools that go with that. So there's no one definition of how to be safe in these situations, but certainly it remains the responsibility of the practitioner, the health practitioner, to be aware of what constitutes safe and to make sure that that's delivered. And baseline, if you don't think that you can deliver that, then you need to take steps so that you are.
Thanks, Curtis. Diana, your perspective as a DHB lawyer?
I guess my perspective is always to remember the basics in terms of basically the same duties and obligations that you have for in-person consultations apply equally in the telehealth space. So really it's always about practical considerations about, well, how can I still meet those duties, but even though I'm doing this consultation in a slightly different way. So it's sort of going through that thought processes of what are we need to do differently to still meet those same obligations. So for example, privacy, for example, you might, for a GP consultation, be in a GP consultation room. So how can you replicate that level of privacy through a telehealth, video consultation? And so that'll be making sure that, your screen can't be seen by other people and those sorts of things. So it's about working through those practical steps to make sure that the same obligations can be met.
Excellent, thank you. Sam King, your perspective from MPS?
Yeah, are there risks associated with telehealth? Yes, there are. I think that there are risks regardless. If you're a clinician, there are going to be risks anyway. And I think that telehealth is really about a skill. And a lot of that is based upon your clinical judgment. And, as Curtis said, it depends on the patient in front of you and patient safety. And if you can think about, I'm going to use my clinical judgment to use the most appropriate tool for this specific patient in front of me. And I think that's something that will become second nature to you the more that you practice in the space of telehealth. And of course, we're all going to be very tentative to start with. Of course, we're all going to be very, a little bit nervous, I suppose, about what we are missing and am I doing this right and am I going to get a complaint? But like any skill, it can be learned. And I think there are ways to do it safely. And I know that someone's asked, is there a course? And I'm not aware of any specific course, but I do actually think that there are resources available to be able to arm yourself with so that you can go up that learning curve quickly.
Thanks, Sam. Just on that, in that regard, not so much on website manner perhaps, but one of our first webinars we did look at some of the topics raised in terms of how to get started in telehealth. And if you go to the telehealth resource site, there's more information there, and there will be more webinars. So keep an eye out for that. Jane, I'm interested in the HDC perspective of safety.
Yes, well, it's the same, and I support what Diana was saying there. The rules haven't changed. The obligations that you have to your patients are the same as they ever were. It is the method of delivery that's changed. So if, should a complaint come through, we'll still be assessed against what is the standard of care. What should we have noticed as practitioners about, this particular case in front of me? Did we do the right thing? So it hasn't changed in any way. Those things will remain the way that they are. Consent will be the same. There will be challenges always, because, if you don't have someone in front of you, there'll be those added challenges about, well, how do I ensure then, that I have caught everything? Have I done the most reasonable thing for this person in front of me?
Thanks, Jane. Rommel, from a medications perspective, what are your thoughts? And there are a few comments here. Actually, there's one from Marshall who's raised this question about security concerns around e-prescriptions and I guess the potential for fraud. Did you want to talk about that in the context of patient safety also?
Yeah, look, I think this is one instance where the digital communications through e-prescribing actually offer a higher level of security than the traditional paper-based model. With the NZEPS, for example, you cannot alter a prescription, you cannot dispense it more than once, but you could forge signatures on a paper prescription. You could make copies of it and dispense it more than once. So this is one instance where technology actually provides a higher level of security than what's traditionally been available.
Thanks, Rommel. Sam Merton, I'm interested now, not only in those safety aspects, but also in supply. We've seen a lot of GPs, moving very fast to telehealth. The majority has been telephone. And I think we're going to see maybe expectations of patients and also clinicians going forward. In terms of, I guess, the rights of patients, not only to choice, but also for our colleagues who are struggling with maybe being able to afford some tech. What are your thoughts around rights to supply?
I think from a college perspective or from a member perspective and the delivery of care, as we move into this new technical age, we need to be really careful about making sure that we don't increase inequities by providing a service that only a few people can get access to. There is options and things that we can look at, and certainly with the GP practices, having some freely available resource for especially for video is really useful. There is lots of conversations about the fact that the technical gear and the computers and screens and video cameras and voice over internet phone systems and all those sort of things are very costly often for a practice, and being able to get them for every service across the country is part of the infrastructure that we need to be requesting and asking for and discussing with the Ministry of Health. The other side of it is that with anything, if there's multiple channels, so if you're using the telephone, often you need to be sure and consent, and this is about the safety side of things, be sure and consent and make sure that you've got the right person there. I always write that it's a phone consultation or a video consultation, or it is an in-person consultation, so that's in my notes and very clear. I also, from a safety perspective, if you're doing a video consultation, you don't know who else is in the room. So I would say, if the hairs on the back of your neck go up, then you need to be really careful and make sure that you are getting people to come in and see you if you think that things sound a little bit worrying, or there's anything that sort of just doesn't gel when you're talking with someone, either over the phone or through a video consultation. And then the other thing is that Curtis mentioned about sending in photos and photos of things. There's not many secure email services that are around, and you can use Manage My Health or a portal which does have some security attached to it. But you need to make sure that if you say to a patient, can you send me a photo, and you're going to send it through a normal email channel, that they are completely aware that it's not secure. So I am always saying to my patients, if you send me a photo on this email address, it's not a secure email address, and is that okay? And then they will agree and send the photo. So you need to be very clear about the security of things that you're sending. Usually I try and make sure that there's only a bit of their body that gets sent, and they have no one be able to recognize who it is that you're dealing with. But at the end of the day, you do need to be very clear with your patients and make sure that they are aware that sometimes these things won't be absolutely secure, and there are breaches at times, and if you can use a secure system, then that's fine, but it's actually very tricky to make sure that every part of the systems that we use is absolutely secure.
Brilliant. Jane, do you have any comments on that as well from an HDC perspective?
From the privacy perspective, again, it goes right back to nothing has changed essentially. So if, as Sam said, if you're not clear that or you can't be sure as a practitioner that that privacy can be respected, then you need to be able to be in a position to ask them, and they need to know about what their rights are. Maybe it's appropriate then to call them in. Where you wouldn't have an excuse is, I thought something was off, but I didn't do something about it. So all the same things will apply as far as the you know, the standard of care that we would be looking for. As far as things that aren't secure, people would have again, it's really about knowledge. You know, do you wish to send it through? Here's the risk of doing so. If that's an issue, then maybe we need to see you in person.
Thanks, Jane. Curtis, I wonder whether I can pick up with you that concept of, I guess, patient consent and understanding what a telehealth consultation is about.
I think it's a really good one, and I'll reflect back to what Jane said about the Code of Patient Rights and the right for patients to be the absolute right for patients to receive informed consent. That does not change. And I really like the way that, Sam, you've brought in that there's a lot of different aspects. It's not in this case just about consenting for, I'm going to give you this antibiotic, here are the side effects, here's how I expect it to work, and etc., and getting that information. It is also about, you know, I like this idea about the consent of this consultation is being conducted in this way. I'm comfortable that I'm able to get the information out that I need to. If it turns out that we can't do the information, or we need to do something a different way, here's what we're going to do. So it's about explaining to the patient and checking every step of the way that they are comfortable. I like the idea, emailing, privacy, who else is in the room? I think these are all excellent practical suggestions. And I'll also just come back to the point you mentioned, Sam, about health equity. Like any technology since, you know, fire and rock, it has the chance to either increase equity across age, generation, Indigenous status, ethnicity, geography, religious or sexual orientation, all of these sorts of things. So it has the opportunity to dramatically improve how we do things, which is, I know, why the ministry is so keen on it, as colleges, societies, practitioners across the land. I think one of the biggest challenges we're going to face with this is, how is it going to increase equity as opposed to increase inequity? My clinic rates through this time for did not attend were a heck of a lot lower when it came to did not answer. And so for me, that was a massive positive. Now, I appreciate I'm preaching to have many converted in this church, but so there's a real good opportunity there. My worry is that we won't seize the opportunity more so than we'll get the opportunity wrong, but both are possible. Mm. And sorry, to come back to the question of consent, that does, consent remains absolute. And if you don't consent to certain things, that would be no excuse if care was found to be suboptimal in any way down the track, just because it was telehealth.
Thanks, Curtis. And Sarah, I'll come to you in a minute, but I will say that there's an equity and improving access in telehealth webinar that's on the New Zealand Telehealth website, and do go to that. I think that was a really excellent webinar. It was moderated by Susan Reid from Health Literacy New Zealand. It's really good. Samantha King, you were going to have another comment. Thank you.
Yeah, just thinking about consent, because we've got we've had a lot of comments from our members, like, how do I consent people? It's going to take a lot of time, and we just don't have time in a 15-minute consultation to do all of that. And a really pragmatic approach is to document that, so that when someone makes an appointment or has that triaging call, you can actually send it out. So it's all written there. You don't have to go through and explain it. So that when you finally do speak to that person, it's easy then just to say, so did you read it? You know, have you got any questions, etc., etc. And that consent process can be very detailed, because it is important that the patients are fully aware. And as Sam Merton has said, there's lots of other things to consider in a remote consultation or using telehealth. I did a webinar some weeks ago, and we look at the practical steps that you can work through in terms of telehealth, and that's actually not just open to our members. We've actually put it on the front page of the MPS website, so anybody can access it, even if you're not our member. So if you want to take advantage of that, please do. It's just some really practical tips about how to move forward safely.
And with that in mind, also Health Navigator New Zealand have got some really great patient information. There's a few questions about how do we prepare our patients. That's a really great website to send patients to, and there's lots of information there. Jane, you had a comment? Yeah,
just following up on that, Sam. And I don't think you meant it in this way, but giving people a lot of stuff to read and then expecting that they've read it, or even asking if they've read it is not, that's not the silver bullet. So you need to be reasonably clear that, you know, they, first of all, they have read it, and that they understand it. So I think we need to go right back to the very basics here, that, you know, it's the same, it's the same, it's the same. But document, all doing the basics well has to be a really important part of this, because that is the way that you're going to at least see what's happened in the past and what, you know, did you miss something?
Thanks.
Yeah, just in response to that, I totally agree that consent is a process. I'm sure that that the clinicians listening are very aware that consent is not an event but a process. But good documentation or giving patients information is a part of that process, and I think it's a really good tool that clinicians can use as part of that process.
Absolutely, I agree.
Right, we might, unless, is there any more comments of consent? We might move on to a little bit of medicines now. We've got a few questions here, and one of actually, which is just talking about directing patients. So, you know, we have this opportunity now with e-prescribing to direct patients to say, well, look here, we will send your prescription to X pharmacy, and then of course there's Zoom pharmacy, or there's, you know, and we know that there are some pharmacies who cover no charge. Diana, did you want to just maybe ask this question, which is it legal for a DHB to promote and advertise to their patients to use a particular pharmacy service? And I imagine that just is for, you know, not just for DHBs.
Yeah, I guess illegal, I wouldn't call it illegal, but it's sort of about our ethical obligations. We're not there to advertise other businesses. It's not so often it will be about consulting the patient about what's most convenient for them, as opposed to promoting any particular business or anything like that. I mean, that's not what DHBs are in the business of doing. So it's about working out what's practical for the particular patient in terms of directing prescriptions, and also what's practical with our systems in terms of whether the pharmacy has e-prescription capability.
Thanks, Diana. Rommel, you may want to comment further, but also with the e-prescribing that we're performing at the moment, there's a few questions about, you know, authentication, particularly with controlled medications. And I guess we're looking at, you know, we have got this waiver at the moment, you know, which is very helpful. I guess, you know, what are the security concerns about that going forward?
Yeah, thank you. So look, just to start off with, in terms of directing patients to particular pharmacies, I completely agree with Diana. You know, this should be about patient choice, but there'll be some instances where, you know, I'm thinking about opioid substitution therapy, for example, where or medicines use reviews. There are particular pharmacies that offer specialized services that that you will want to direct your patients to. So with regards to the waivers that we have an enduring waiver for signatureless prescribing if NZEPS is used. So that really paid dividends with particularly GPs, but also with the hospital services that were able to use NZEPS around to move to telehealth consultations for outpatients and GP consultations. And so we saw NZEPS just, I think, predominantly driven by the fact that we were now able to do signatureless prescriptions. We saw a big rise from 300 to, I think, 800 in the last 800 GPs just in the last 6 weeks. So which has been great, and that's an enduring waiver if NZEPS is used. So GPs and others who use NZEPS will have that forever and a day. There's a temporary waiver for organizations and systems that were yet to get onto NZEPS, and we did that around. We did that because we knew that exchanging paper prescriptions was difficult and posed health and safety risks. So the Director General signed that off, and that expired. That there was a temporary waiver. It expires on the 25th of June. The DG is looking at options to extend that, but to organizations who are working towards NZEPS. So we're really keen to get the sector onto NZEPS because it's safe, it's secure, it provides a lot of really good benefits both for patient, clinician, but also the system. But we do recognize it's going to take some work and some time for organizations to get there.
Thanks, Ron. And now may be a good time to say that, of course, the review of the national assets reports out, which has exposed a huge, technology deficits for the, which, as you described, may take some people to overcome in order to be able to get their prescriptions through NZEPS. Now, why don't we just move on a little bit to talking about best practice and guidelines? We've got guidelines for almost everything. Is there a difference between best practice in telehealth and best practice in other health? Sam Merton, you want to kick that conversation off?
I think with any conversation about best practice, there is no difference. You're doing the best that you can with the service that you're providing. And so whether it's a telehealth service or an in-person service, it should always be best practice. I think there's certainly, I know that many of us have guidelines and articles or commentary or statements on telehealth, and many of them have been produced sort of relatively recently. There's a comment there about what literature are we using, and has it been in the last 15 years? And I think, Ruth, I'm sure you've been involved in telehealth for a very long time, but the college statement was put out in 2017 and was written mainly by Richard Medlicott, who is very involved in telehealth and does lots of video consulting himself and has been a champion of it. So, and it's very broad ranging in that it talks about all sorts of different aspects of telehealth and how you can make sure that you're doing it well, but doesn't necessarily say these are the 15 steps that you have to take. And I think because telehealth does mean a whole lot of different services, it's not going to be a one size fits all. I think it's more about ideas that you need to consider and safety issues that you need to think about, and what things you need to put in place to make sure that you are secure for your patients and that they're getting the best deal. So I think there's probably room for those to develop over time, but I think there is plenty of stuff around that people can look at currently if they want to get something started anyway. Yeah.
Thanks, Sam. Curtis, your view on guidelines? Do they need to be different?
I can speak to the Medical Council guidelines in just a second, and I will do so because one of them is hot off the press and coming out for consultation probably, I expect, within the next few days, or certainly within the next week. That's the statement on telehealth, and that's in response to a couple of even newer hot off the press things in the last revision just in March. But I just seen one question I'd like to just address in the Zoom webinar chat. Someone had asked why is consent needed for telehealth appointment and not face-to-face? And is acknowledging the appointment and showing up consent? No. Consent is more than just showing up, and that's implied consent. Why consent's needed? It's because it is different, and we can't do the same things in telehealth that we might otherwise do in an in-person consultation. For example, I mentioned before, I think, well, let me rephrase. As a renal physician, I really like to get blood pressures and assess fluid balance, peripheral edema, listen to chest, JVP. I have to say to the patients, and I have been saying to patients who I've been doing telephone consultations for, this is a telephone consultation. I can't do this, this, and this, and we have to acknowledge that. Have you recently, or can you go and get a blood pressure taken and this assessment done by your GP this week, because I have these concerns? And if I don't do that and explain why this consultation is different from another kind of consultation I might do, and the patient later on came down and, well, my blood pressure wasn't checked and they didn't assess my fluid and I wound up in hospital 3 days later, I'm not sure I'd have much of a leg to stand on if I hadn't discussed that with the patient. So I think it's those kind of things that you're needing to consent for in a telehealth situation, to maintain your safety and the patient's safety. And how's it different from face-to-face? In some ways it just is. But what we're trying to achieve is the same standard of consent and the same standard of practice, albeit through different means, and acknowledging that they're different as part of the consent. I've probably said enough, and I know that didn't answer the question. What was the question again? It was about statements. And...
It was about guidelines, but just while you're saying that, I know that I've had a few questions from people about, well, what about if, as a practitioner, I feel uncomfortable? So it may be the patient's choice. You know, how much of a risk do you pass to your patient in making that decision? So you're at the top, and you know, my practice, you're on the top of Coromandel. And that drive is, you know, 2.5 hours, and the patient makes an informed decision that actually I'm going to risk not being able to examine my abdomen or whatever. You know, it's difficult, isn't it? Because you don't want to say, well, no, I'm not going to see you. So how do you balance that? You got any thoughts?
Well, my view is that you as the practitioner are responsible ultimately for that. Yes, you have to take into account the patient's wishes, but in that case, it becomes an example about really explaining the risks to the patient and ensuring that they are informed. And, you know, and possibly that you may be in a position where you can't conduct that in the same way as a surgeon might not. So look, this operation's too risky, this patient's too risky for dialysis, we can't put a kidney transplant into this patient. It may just be too risky. And so here are the alternatives that we have to do to keep you safe. And we might have to have that brave conversation if we genuinely believe it.
No, I like that. Too risky. I like that. Diana, do you have any comments on that?
Yeah, I'd reiterate the same points really. A lot of it is about, first of all, explaining the risks, the consequences, and obviously the choices available. But they will reach a threshold where it's just actually, you know, not appropriate to continue without doing the in-person consultation. So it's that balancing act versus, you know, you are making the patient have that informed decision, but there will come a point where actually, you know, the risks of not seeing the person in person and doing those additional tests means that it's just not reasonable to continue down that line. So it is sort of fact specific, but it's all about balancing, you know, the fact maybe the person won't be able to come in person if you don't at least give them this option, versus a point where actually it might be it's just not, it's too risky to continue without that in-person consultation. So it is fact specific, and a balancing act really. But so much is about making sure the patient is informed of all the consequences of different steps.
I mean, a whole bunch of people might want to take off from Queenstown in the fog and the wind, but the pilot might have to say, sorry.
Yeah, exactly.
Absolutely. So it's in terms of the informed consent, it's what would a reasonable person in that situation want to know in terms of the risks and the benefits, the costs, and the options available. And if it comes to a point where as a clinician it just is not tenable to make that decision, like take off in the fog, then you need to call it.
And provide alternatives, like Air New Zealand, get on a bus.
Yeah.
Go to your local options,
yeah.
In fact, we saw quite a few people, I have to say, in my emergency department where the GP wasn't able to examine, and they sent them to us, and that was just fine.
Yeah, sorry, Ruth. So I just want to make it clear: you can't just drop the patient at that point and walk away because they wouldn't do something you said. You still have to carry a degree of professional responsibility to hand over their care and provide options, you know, as far as is very reasonably possible.
You know, thanks, Curtis. That's a really important point. Jane, just while we've got you having a chat there, do you want to talk a little bit about recording of consultations and what rights the patient has to record a consultation?
This is a real tricky one. I don't think there's an inherent right to record your consultation. This is something that the two of you need to be comfortable with. It is the patient's information, but to some extent it's also, can we effectively carry out this consultation? So it's a conversation that needs to be had. It's not illegal for someone to covertly to record something that they are a party to. So at any time I might be recording, for myself an interaction that I have, but it's about trust and confidence. Someone just rocking in there and saying, look, I have the right, it's just not as black and white as that. I think as a clinician, you've got the right also to have a conversation about it. Are you the right place for this to be happening? Some people aren't so concerned about the recording of the consultation, others are. It may well be that someone is recording it anyway and that won't be illegal, but I think that there's much more to it than simply rocking in there and saying, I have the right.
Mm. Thanks, Jane. Sam King, do you have a perspective from your members who?
Yeah, we do get asked about this quite a lot, and if you believe as a clinician that it's going to impact on the nature of the consultation, which I can understand that it possibly will have an impact on it, you're quite within your rights to say no, we can't proceed. The other thing would be if it impacts upon your own privacy, although generally speaking that's not going to be the case because you're talking about the patient's health, you're not talking about yourself. But if it's going to change the nature of a consultation, I think it would be reasonable to say that to decline. But as Jane said, patients often record consultations surreptitiously. And so you have to assume that that's going to happen. One thing I would strongly recommend is that clinicians don't record consultations covertly, that you do get consent. And I'm sure that Curtis has something to say about that. Yes. But yeah, just please be very careful.
You can't be the recorder without the no.
Sam Merton, did you have a comment as well?
Yeah, so I think what Jane was saying about and Sam about the nature of the consultation. An example we had just ourselves the other day was a mum who was coming in for to have an immunisation with her child and wanted to record the immunisation with the child, and the nurse was very uncomfortable with doing this. And in fact, the mother wanted to hold the phone and hold the child while the child had the immunisation done, which is actually unsafe in the first place because you have to have the child well secure. And so there was quite a long conversation about, no, you can't do this. And even surreptitiously, this mother was trying to get the phone going so that she could be filming the whole process. And the nurse was very clear that she didn't want this to go on. And I think the other thing from a privacy perspective, and certainly we to discuss this afterwards, because in the hospital there's very clear guidance in our local hospital about, you can't film or record anything in our setting, and then if you do want to, then there is a conversation. So if you've got some signage or something that says, we prefer that you do not film or record or photograph while you're in the service, because there are other patients who might be around. There's the only privacy of the clinicians themselves. But then once again, if they do it in a clandestine way, then we have no comeback, and that's fine. We just have to live with that. But I think it's respect for both the clinician and the patient to be able to have a conversation about it.
Thanks, Sam. There's a couple more questions here on NZEPS, and I guess, Rommel, it might be interesting to know what further developments might be planned with NZEPS, if there are any, or are we concentrating on prescribing through? And I see there's a question there about the use of SMS for patients through NZEPS. Do you have any comments about further developments?
Yeah, look, we've got we've no shortage of ideas and for improving it, and we're getting the more people that are using NZEPS, the more feedback we're getting. And our focus at the moment is really making it more usable. So we're getting feedback that some aspects of NZEPS prescribing through NZEPS is clunky, takes too many steps. We're getting feedback that the New Zealand list of medicines isn't universally used, which is well, the NZULM, it's a great enabler for safety because it allows decision support and getting alerts and warnings that might prevent incorrect prescribing. So that's really our focus at the moment. But look, we're constantly looking at what other countries have done. So the one about SMS. So I think it was Mahesh that asked about whether in the future a patient might be able to walk into a pharmacy with their mobile phone and hold it up and scan it at a kiosk just like you do in Air New Zealand. That's absolutely the kind of experience we want to achieve in the future. We've just got some regulatory barriers around that because at the moment the full form of the prescription is still what's required by the medicines regulation. So until those things are kind of changed, we're a little bit kind of hampered in how far we can go. But certainly that's one of those things that we want to pick up when we look at the regulatory framework, because that's the kind of experience we want to achieve.
Yeah, I think it's interesting how fast legislation can change when it needs to, even if it's a waiver or over this last period of time we've seen a huge amount of change, haven't we, in the systems. I think we're coming closer to wrap up. I think just before we go to a bit of a panel wrap up, I'd quite like to address the question of the need to examine a patient before a first prescription. And Diana, I might start with you because I know that we went through some of this thinking when we were doing Smart Health and the need to examine a patient prior to prescribing, or a medical certificate for that matter. Did you want to just talk to that briefly and then we might ask Curtis?
Yes, well, I guess it's I think the Medical Council statement is quite clear on that in terms of you must meet them generally before prescribing unless it's more an emergency situation. So I think that sort of in a way guides a lot of the responsibilities in this area. What's that, sorry? But obviously I think it's circumstantial. So I think there might be situations where perhaps the patient might not have any other option and it's needed urgently, in which case it would be appropriate if all the other duties could be met in terms of making sure you've got the appropriate information and everything, asking sensible questions to verify identity, so date of birth, and doing any cross checks as much as possible to verify that. So it's a lot of it's that common sense of verifying identity, and if you aren't able to see them in person first, then also making sure you've got all the relevant background information to make a sort of sensible prescribing decision at the end of that.
Yeah, thanks, Diana. I guess it's that definition of emergency is a little bit of a flux as well, isn't it? And I think also, now that many of us have got access to really good notes, for example, your colleague might have seen that patient just the day before yesterday, but you've never met them. Where is your responsibility like? Curtis, did you want to speak to that maybe?
Yeah, thanks. I mean, that highlights the importance of entering contemporaneous notes so that other practitioners could follow on, especially given the fragmentation of care that goes on now. More important than it ever was, possibly, and it's always been important. I'll just quote, this was the statement on Telehealth, which is, we just considered at Medical Council on Tuesday, and it's going out for consultation this week, and we've amended that slightly the bit around seeing a patient for the first time. So it's before prescribing any medication for the first time to a patient, and in-person consultation is best practice. It was good practice, but that led to people saying, well, if that's good practice, anything else must not be. So we said is best practice. So in-person is best practice, but where an in-person consultation is not undertaken, consider a telephone or video consultation, making sure that you've got the patient's medical history and all these other things that flow on from the current statement are the same. And so that's probably the big change, is that it no longer has to have an emergency. It's no longer if it's not possible because of exceptional circumstances. And I think that's probably one of the biggest business as new changes. The rest of the professional obligations, as we've already discussed, remain around consent, making sure you're familiar with the drugs, explaining the side effects, keeping up to date with all the regulations around the drugs, etc., etc. So that's probably the biggest thing. It no longer has to be in exceptional circumstances because we're business as new. That's coming up for consultation. And because I know we haven't got to all of the Q&As and I haven't heard from people what the other concerns might be, I'd like to say, at least for the doctors who are going to get this statement out there, please feed back on the statement and other stakeholders with any concerns you have about not only the statement, but any questions you have around telehealth and how the Medical Council statement might be able to support that whilst retaining its fundamental protective role.
Excellent, thanks, Curtis. And we should also say that the New Zealand Telehealth Leadership Group's got a close relationship with the Medical Council, and we've got a Medical Council member who sits on our group, which is great as well. Well, I think it's time to start wrapping up, but I'd be interested in your final pearls of wisdom. Sam Merton, shall we start with you?
I would just like to say to everyone that we should grab the nettle and run with it, and that telehealth is here to stay. And for those of us who know our patients well, it's a really good string to our bow, arrow in our quiver. You know, it's a really good service that we can provide for patients, and I think we would be remiss to not continue to have it available on offer. But we still need to be very cautious and make sure that we're doing it very well.
Excellent. Thanks very much, Sam. Sam King.
Yeah, I would echo Sam Merton's comments that I think it is here to stay, and it's a very useful adjunct for all clinicians to have as part of what they can offer patients. There are ways to do it safely, and from a medico-legal perspective, can I just suggest that you do familiarise yourself with the Medical Council statements, particularly around prescribing, telehealth, and about good medical practice and how to do that. If you're really cognizant of those things, I think that'll guide you as to how you can conduct telehealth really safely. But I think it's a great thing, and we should keep it.
Thanks, Sam. Jane?
It is a really important tool, but it is a tool. And the basics remain the same. So are you still providing the best service for this individual? Are you doing so with their consent? Do they know what the risks and benefits are? Are you aware of where the drawbacks are, but also the benefits? And the benefits are many, particularly in the equity space. We can see how, you know, there's just so much more access for people who wouldn't ordinarily be able to access. And so, you know, don't throw the baby out with the bathwater. There's just so much to be gained here.
Thanks, Jane. Have you seen any, or are you aware of any complaints that have come through yet to HDC, which are specifically in regards to telehealth? Because I guess we're all waiting almost with bated breath, because there's sure to be, aren't there? Yeah, there's sure to be. I'm
not, they haven't made their way up to me yet. No, I'm not aware yet. You know, if it's around the area of consent or that, you know, I have no doubt that at some stage there will be, but that won't be because it's telehealth. That will be because something very basic has failed. So someone feels perhaps that they haven't given consent, or they feel that the standard of care was inappropriate. That will be the underlying basis of the complaint. It won't be that there's a new medium here that has some real benefits to everybody.
Yeah, thanks, Jane. I think that's really, that's really insightful and helpful. Rommel, you've got your pom-poms out and your NZEPS behind you. Yeah, anything you want to leave us with?
Look, on that, you know, we've taken such a huge leap forward, and it took all of us a lot of courage to get here. And you know, now it's really not the time to go backwards. We've got momentum. We've finally got momentum, and we just need to take this one for the ride and keep going forward, keep charging ahead, see problems, solve problems, move on.
Excellent, thanks, Rommel. And actually, we've just got I'm going to throw in a little question here, just because we can, and we haven't covered it, which is about international practice. So you're a New Zealand doctor, you're registered in New Zealand, you're in Australia. Is it okay to see a patient in New Zealand?
Oh yeah, look, I do. It's covered off in our telehealth statement. And actually, I acknowledge that there are an enormous variety of people who are attending tonight. So I hasten to add and acknowledge that the medical profession is one tiddly part of healthcare, and that there are other standards from all of the other regulatory authorities and professions and professional bodies out there. That said, I can give you the Medical Council's view on it. Well, the statement speaks there, so people can go and read it, but it gives clear guidance of if the patients, if you're outside dialing into New Zealand, you have to, where are we? If you're in New Zealand and only provide telehealth services to patients who are in another country, so this is the, say Ruth, you want to be, providing telehealth to Outback Australia, you're not actually required to be registered with the council because you're not practicing medicine in New Zealand. I suggest that, remains a good idea for a number of reasons, but you are certainly subject to whatever jurisdiction might come from over there and opprobrium, etc. And if you're providing care from New Zealand patients, from New Zealand to patients in another country, you are subject to our laws around prescribing, etc. So you can't just go and prescribe something in contrast to what Rommel might say, in the EPS, that you've got to follow the New Zealand prescribing laws. And all the waivers.
What if you are in general practice and your patient has gone to Australia for a holiday?
Well, you can still provide them over there because you'd be providing telehealth services to, at that point, patients who are located in another country.
So long as you're compliant with their regulations, you don't need to be registered in that country to provide care, even though your patients, that starts getting a bit tricky, doesn't it?
Well, see, here's the thing. Council can't require people to be registered here from overseas who are providing in. So there is a slight element of buyer beware of people who are obtaining medical advice and consultations from telehealth professionals overseas, outside of, formal frameworks like teleradiology, for example, which is a whole
Sam
other.
King, you had something to add?
Yeah, so you do need to ensure that if you're in Australia but treating patients in New Zealand, or the other way around, it doesn't matter. The Australian council might require you to be registered there. And so often you have to be registered in both countries. And in New Zealand, we don't really have litigation because of ACC, thankfully, but overseas you can. So it's possible if you're treating a patient in Australia or the US, for example, they can reach across and bring a claim against you in their country. So you need to be aware of that. ACC does not cover you for that. So you need to think very carefully about which jurisdiction you're working in.
So make sure your professional indemnity is up to date as well.
Yes.
Nice
Diana, do you have any final words?
Well, I guess I'll just reiterate what everyone else is saying in terms of telehealth is a great tool in the box for medical professionals to have. And also in terms of, I think, giving people comfort if they're new to this area about the fact that really the legal requirements are the same as in person. So it's not like you're going to be tripped up by anything. They're the same requirements. And really, I think as much as you can in advance, having systems in your place of work where you sort of have gone through their thought process of how can we still meet our consent requirements, how can we still meet our privacy requirements, and have those sort of set up as much in advance as possible. And that just can give you extra comfort in terms of moving into this space and making the most of all the guidance that's out there already. It's also a good idea as well.
Thanks, Diana. Curtis, last words, my friend.
Oh, last word. Well, I had first words. I feel a bit bad, really. No, can I give last words to somebody else? But I want everyone's last words, though, on this consultation when it comes out. And then they can have heaps of words.
Yeah, absolutely. We're a big plug-in for that. Everybody keep an eye for that. So you'll send it out via the sort of... I
think that's coming out via email to professional and stakeholders, et cetera, hopefully within the next week. And there's a whole lot of questions on here that we haven't answered, but they're really exciting. And I can't believe where the hour's gone, and I'm sorry it's over already.
I know. Well, we'll be addressing some of those and probably sending them off to you folks. So our practice for those of you who are with us is that we will keep those Q&A and particular ones we will direct to bodies, and we will pop those up on the Our next webinar is on ensuring effective communication. And I'm really looking forward to that. So that's another patient-centred conversation. So for those of you who haven't also looked at the equity one, I can't rave about that one enough. I think that was a really great webinar. Health Navigator are partnering with us to do the ensuring effective communication one. Otherwise, I think all that is left to me to do is to thank our amazing panel for giving up your evening to talk with us. I so appreciate it. I know all of those participants have enjoyed it as well. Thank you very much, everybody. Ka kite anō.
Ka kite anō. I think we should do this in person sometime.
We should.